Hi class, I'm Kate Leiden. I am your repro instructor. For distance learning, this is a new experience for all of us, I'm sure. I am a labor and delivery nurse at St. Mary's and per diem at Midcoast, full-time at St. Mary's. I have been for a little over 3 years. I graduated from USM with a bachelor's, and I'm very excited to teach you. You guys are my 5th clinical group this semester. Fortunately, most of the other kiddos students got to come to clinical physically. And you guys are doing a completely distance learning, which is a little better than the middle group, which got kind of half and half. You will get the full set of weeks with me this way. So hopefully that teaches you quite a bit. We will keep in close communication. The first thing I want to go over with you though is going to be a head-to-toe assessment of a newborn. This is our newborn today. This is my 17-month-old daughter's doll. The best I can get you. HIPAA purposes, I can't do videos, St. Mary's won't allow it, of a maternal head-to-toe and a newborn head-to-toe in person in the hospital. So we're gonna do the next best thing and do this newborn head-to-toe this way. So when you're assessing a newborn for the first time, you will be the newborn nurse in a delivery. When the delivery occurs, you will be there to do 1-minute and 5-minute APGAR scores. We'll talk about that a little later. And then you'll do the head-to-toe assessment of the newborn after those first sets of vitals are done. So we can perform the head-to-toe on a mother's abdomen. So the baby's on the mom's chest, we can do it there. We can wait. Within an hour and a half, we have to get a weight and a length and abdominal and head measurements. So we can wait until we're doing that, which makes it a little easier, and do it at the scale or in the bassinet. If we're doing it that way, babies lose heat very quickly, so it's best and most appropriate to keep the baby swaddled with a hat on to start your assessment. And then as we go, we'll take off what we need to and put it back on to continue our assessment to keep the baby from losing too much of its temperature. So we would start, if this baby was swaddled with a hat on, we would start with the facial features, just seeing that the baby is symmetrical bilaterally, that the eyes are present, that they are symmetrical, and that they don't have any issues opening, any skin tags, anything like that. We would make sure that the nares are patent bilaterally. You can see that when a baby's at breast or when a baby's at bottle, because they are obligate nose breathers. And so if they are drinking and they don't keep popping off the breast or off the bottle because they can't breathe, then you know that they're patent. The other way to do this is to block one nair at a time and make sure both nares are patent as well. You would look at the ears to make sure that they're evenly and appropriately set. So you want to make sure that bilaterally they're symmetrical and that they come in line with the eyes. If they're very low set, that could be a marker for genetic conditions such as Down syndrome. You would make sure that the mouth looks patent and symmetrical. You want to look inside the mouth, make sure there's no newborn teeth. That can rarely occur. It would need to be removed as it's a choking hazard and it's not a real baby or adult tooth. You would look for something called Epstein pearls, which are little white spots on the gums, which can be a normal finding. You would stick which I guess I should have started with that. So much easier to do this bedside. But you would pump into the room and wash your hands, introduce yourself, right? And then you'd be doing this. So you'd have a fresh set of gloves on because the baby's not bathed. And then you'd stick a clean ring finger into the baby's mouth. And you'd feel the top of the hard and soft palate and make sure there's no openings. You'd make sure that the lips, there's no cleft palate. And you'd want to make sure that the palate is completely closed. And then you would make sure, looking at the tongue, that there's no crazy tongue tie where the frenulum comes to the tip of the tongue, which can make feeding harder. And down the road, speech might be altered. So that is the head to toe. I mean, that's the head portion or the face portion of the head. Now you take off the hat, you'd feel for the anterior fontanelle, which is usually about 1/2 inch to 1 inch above the forehead. Sutures might be overriding where you can feel the ridge of the suture. They might be separated. There could be some swelling on the head, some capit. I have a really good diagram to show you guys about that and teach you about that. But heads coming down vaginal canals, there's always a little bit of trauma, whether it's just some swelling, which is a normal finding, or whether there's maybe some bruising or some bleeding. And then the posterior fontanelle is somewhere in this range here. So you just feel for it. Make sure that you're feeling that it's soft, that it's flat, shouldn't be sunken in, shouldn't be bulging, it shouldn't be bounding. And so you want to just feel for that. You want to make sure that at the back of the neck that there's no openings. So once that we have seen that the head is good, we'll put the hat back on so we don't lose heat, and we will unwrap the baby, and there's a diaper on. And at this point, I usually feel the clavicle and rotate the arm, making sure there's no break in the clavicle. You would know that there's a break if you feel crepitus there. So like a crackly poppy feeling under your fingers. The baby usually would be bothered by that as well. If you do feel crepitus, you just want to finish your head to toe, wrap up the baby, notify the pediatrician, and do not palpate it again. You don't want to cause damage to any nerves. I make my way down, checking that all the digits are present and that there's no webbing. I would feel the abdomen to make sure the abdomen is nice and soft. I would make sure that the umbilicus, which has a cord stump and a cord clamp, that the clamp is tight and that it's not bleeding. I would make sure whether or not there was an umbilical hernia or any diaphragmatic hernias. You would go down to the baby's legs. Again, I would check to make sure all the digits are present and there's no webbing. We also check for sole creases. So how much of the foot, 3/4, 2/3, shows like a print creasing. A premature baby will have less creasing. A term baby or even post-term baby would maybe have some peeling even of the skin. So normal findings in those cases, but it's of note on the head to toe assessment. You want to be feeling Ortolani's maneuver, and you want to check to make sure there's no hip clicks. If there's no hip clicks, then we note that. If there is, we note it, and when we would notify the pediatrician if there were clicks, so they could look for that. And then I would make sure the baby's genitalia looks normal, and if there's anything to note there. So sometimes there's hymenal tags in baby girls, sometimes there's undescended testicles in baby boys. You would just want to note that. So looking at the genitalia and noting how that is visualized. And then you turn the baby over gently and you just check to make sure that the spine looks straight and normal, that there's no openings from the top to the bottom of the spine. You kind of spread the buttocks to make sure there's no dimple at the top of the butt. And if there is a dimple, you want to spread it and see if you can find the bottom. If you can't, they'll have to ultrasound that. But again, that would be a finding you would want to notify a pediatrician about, because that can be a sign of a spina bifida. And then you can check for reflexes. So the reflexes we check for in a baby are the Moro or the startle reflex, where we can lift a baby's arms and let it go, and they'll do this like Moro reflex. And then I always check for palmar, where you stick your fingers in a baby's palms and they grasp them. That's a normal newborn reflex. When you were in the mouth, you were checking for a suck or a gag reflex. With the feet, you want to do a Babinski, which is from the heel up, and they spread their toes. You want to do that bilaterally and make sure it's there. And then the plantars, you put your finger below the toes and they kind of grab onto your finger. So those and the stepping reflex are the ones we check for, where a baby, if you put a baby upright and support its body, it will have one leg down at a time. When it puts the other one down, it lifts the other up. So normal reflexes that we check for at birth. And as long as all of that looks normal, and of course overall skin condition as well, acrocyanosis is usually noted at delivery or within the first few days, where the palms and the feet are purpley and the rest of the body's nice and pink. You want to make sure they're appropriate for ethnicity. Color-wise, you want to make sure there's no rashes, birthmarks. If there are, you want to note them. Always checking to make sure that the heart rate the respiratory rate, the temperature are normal. You want to just basically write what you see, chart what you see. And then if there's anything concerning that you note, then you would want to speak with your pediatrician directly, let them know what your assessment findings were. And at that point, if there's a reason, they will come in early and assess the baby themselves. So thank you, little Paula, for being our subject today. If you have a baby doll at home or a little sibling or something, feel free to physically practice doing the head to toe. That would be a good experience. Obviously, we want the bedside experience and we can't really get that this time. So you would want to check for those things. Feel free to Google, and I'll probably look on YouTube and see if there's a couple different head to toes that I could put out there for you. But this was mine. Thanks for listening.